One. Does anybody have any questions? Enid, are you able to hear me? Wave if you can. Okay, good. Okay, then I'm going to go ahead and start again. So I mentioned that surgery is a major life stress or life stressor, regardless of the nature of the surgery or regardless of the individual. And obviously, that doesn't mean it's a universal response, meaning that some people are going to be more stressed by it than others. But there are basically two categories of stress. And so that first stress is universal. Because it represents a threat to the integrity of our body, there will be some adrenaline release during that perioperative period, and the client may experience the general adaptation syndrome, that fight or flight response that we talked about. But there can also be a great deal of psychological stress, a great deal of anxiety and fear. And I have listed a slew of things that somebody might be afraid of or concerned about. And so I'm just going to click through them. You've got them all listed there. But I want you to imagine for just a moment, if you were going into a procedure and you did not know the answer to one of those lines, if you did not know what the surgeon was going to find, if you did not know how much pain you were going to experience or whether the nurses would take you serious enough to relieve it, if you did not know that whether that tumor was going to be cancer and what that would mean to you and your family in the post-op time, or maybe you've never had anesthesia before and maybe you're afraid of what that might feel like or be like. I can remember the first time I had anesthesia when I was old enough to know. I had my tonsils out when I was 4, so I don't remember that experience, but I remember having my wisdom teeth out, and some of you have perhaps had that done. But because of the nature of my wisdom teeth, they literally were growing sideways, then I had to have IV sedation. And I can remember the anesthesiologist doing things with my IV and then turning away doing things on his little table. And then I remember the room beginning to get dark and cloudy, and I literally thought, something's not right here, and he's not even paying attention. But I was already too far under to be able to speak. And I remember the last thing I remember before going under was extreme terror. And then I woke up later. Okay, so there are plenty of things that the client, because they have not experienced surgery every day like you have as a perioperative nurse, they need your compassion and your support. So what can we do to help them through those stresses? Well, therapeutic communication is our number one intervention. Being a good listener and using those therapeutic techniques to redirect their thoughts to help them be able to voice their concerns in a way that you can respond appropriately for them. Because they may have difficulty telling you what they need to tell you or want to tell you. And they may be too embarrassed that, I'm 56 years old and I'm afraid to tell you this. But through therapeutic communication, they may learn to trust you and get those answers that they need to allay their fears. But remember, answer the questions, but provide only as much information as the client wants. Don't tell them all the what ifs or the what mights happen. Use touch if it's appropriate for the culture and the situation. And then recognize that there are certain types of procedure, for example, mastectomies and related to cancer, that there are support groups out there that if as a pre-op nurse, you will simply notify those organizations. They will send a cancer survivor to sit with that client and interact with them during that pre-op time. They will be that support person during that diagnostic workup. And recognize that for some clients, we just may need to medicate them with an anxiolytic to help them get through that stress. All right, surgical wound types. When we talk about surgical wound types, we're talking about 3 primary ways the surgeon deals with a wound. So the first one is what we call primary attention. It means that when they make the incision, they seal it back up with sutures or staples where the edges are close to each other. We call that edges well approximated. and that leaves the smallest scar and heals the best. It's a clean wound, meaning that the wound was created only by the surgeon. It wasn't from an injury first. Secondary intention is when there's been a traumatic injury and the surgeon cleans out that injury, but he leaves it open to heal from the inside because he doesn't want to close up bacteria in the wound and create an abscess. And so we call that secondary intention. The wound will literally fill in with granulation tissue from the base of the wound and bridge the gap over time. It takes quite a while, sometimes several weeks, depending on how big the nature of that injury is. And then a tertiary intention is a contaminated wound that is closed up at a second procedure. Okay, so it might be a traumatic injury of some sort, like a stab or puncture wound that is left open initially, and then once we determine that there's no abscess forming, the surgeon goes back in a second time and seals it up so it can heal most effectively. All right, so there are multiple things that can affect healing. So we're going to go down through each of those things in the list. So this is where you get to write probably more on this slide than any of the others, perhaps. So age affects healing. The older a person is, the longer it takes for that person to heal their surgical site, regardless of whether it's primary, secondary, or tertiary. Circulation. Anything that causes a decrease in blood flow to that area leads to a decrease in nutrients and oxygen to that tissue, making it very difficult for that wound to heal. So that might be diabetes. So it might be the sclerotic vessels that occur with diabetes. It might be peripheral arterial disease that we're going to talk about in just a couple of weeks at the end of March. It might even be a cardiovascular problem like heart failure, where it's not the vessels, it is the heart muscle itself that's not pushing the blood flow effectively to the tissues. The third one is part of our ABCD, and that is corticosteroids. Remember, corticosteroids impair tissue healing, and they suppress the inflammatory response, meaning that we don't always see those 5 signs and symptoms of of inflammation occurring before it's too late. The presence of a foreign body. So if anything is left inside the wound, it will interfere with healing because the white blood cells must consume it. The macrophages must consume it and eliminate it. They have to liquefy it and then carry it out through the lymph system, and it just delays the process. One of the best examples that I experienced of this was I had difficulty with my shoulder and had to have physical therapy. Not this summer, I think it was the summer before. I think it was 2017 or 2018. And basically, in the course of getting to know the physical therapist, they told me an interesting story about a firefighter who, in the course of a 4th of July fireworks demonstration, had a firework fall over and shoot him in the arm and explode in his arm. So he had this nasty wound that was initially taken to surgery, cleaned and debrided, and left to heal. Well, eventually it did heal over the tissue, but it started draining from one corner of the site, this brown, foul-smelling liquid. And over time, the wound began to open up more, and it became worse and worse. Well, ultimately, what they ended up finding out was one of those paper wads that fireworks shoot up in the air to explode had still been embedded in the muscle and had been missed in that original procedure. And so the body was trying to liquefy and remove it, but it was going to take weeks to do that. So once they went back in a second time, found it, removed it, it got well pretty fast. Okay. Infection. It is one of the most common causes of a delay in healing. So we try to prevent it, and we try to observe for it. Weight. We already talked about how an increase in weight causes an increase in lots of problems during post-op time. But one of the problems it causes is an increased stress on the suture or staple line if it is the adipose tissue of the abdomen that has been incised. And remember, I said adipose tissue is not very vascular, so it does not heal well to begin with. Nutrition. And so we need increased protein and energy for tissue healing. We need the vitamin C and B vitamins for tissue and collagen formation, which is some of that scar tissue being formed. We need zinc, which is a mineral for wound healing, as well as for cell-mediated immunity. So we need protein, B vitamins, zinc, and we need plenty of calories. All right, any questions about the wound? All right, let's talk about post-op care. Give me just a second. Madison, if you close that. It's kind of distracting me. It may not be distracting you all. All right, so post-op care. One of the first things you're going to do when you receive a client from the PACU nurse, so if you're on a surgical floor during that post-op time, you're going to receive a report and you're going to obtain pertinent information from that PACU nurse. And that pertinent information includes some of the things we're going to talk about and some other things that are included in your post-op report, part of your textbook. Okay, so there's initially, after you receive that report, you're going to do that initial head to toe. And you're going to do a focus assessment specifically on that surgical site. And you're going to compare all your findings to those pre-op things. Okay, so you're going to compare the person's vital signs. You're going to compare their cognition. You're going to compare their mobility. You're going to compare their nutritional state, their color, etc. Frequent vital signs. Frequent vital signs simply means that because of the nature of surgery, because of anesthesia, as well as intentional injury to tissues and the lysings of blood vessels, then a person's cardiovascular system can be compromised very quickly during the post-op time. And so frequent vital signs for most facilities will include something similar to what I'm about to describe. Recognize that it's not so much the specific sequence that I'm telling you as much as the fact that you're going to assess until they are stable. So you're going to take an initial set on arrival, and then every 15 minutes, typically times 4. So for that first hour, you will take them every 15 minutes. If the patient's vital signs are similar, but then I think your book says 15 to 20 points of their baseline, the pre-op vital signs, then you can spread them out to every 30 minutes, typically times 4. And then after that, your facility may either allow you to go to every 4 hours, or it may require you to continue at every hour for the next 4 hours, etc. But eventually you will spread them out to every 4 hours. Always comparing them to your pre-op baseline, as long as the pre-op baseline was not somebody who had trauma. Okay, so somebody who came in because they've been in a motor vehicle accident and cut their leg off and their vital signs are horrible, then you're obviously going to compare to what normal ranges would be. Okay. You're going to assess their IVs, their tubes, their dressings, their drains, recognizing that some of the drains will need to be emptied periodically and documented as part of I&O, recognizing that IVs should not be hung by gravity lest they get away from you, and a patient who has cardiac problems could then get into a fluid overload situation. So many times they will come to you from surgery by gravity and you'll have to place them on a pump at the prescribed rate. And then tubes, meaning like an NG tube or a Foley catheter, you're going to assess all of those and document what you observe. You're going to monitor their I&O because of, again, the potential for there to be significant changes in that. And so what's our minimum, I think we're at Tonkwall, what's our minimum urine output that Mrs. Martinez taught you last fall? 30 mils per hour, absolutely, good job. Pain and discomforts, you're going to address those pain and discomforts, and by discomforts I'm talking about nausea, especially nausea and vomiting. So many times when we address pain, we also have to address the nausea and vomiting simultaneously. And then make sure you address the safety issues, keeping the bed in low position, keeping the head of the bed raised if their level of consciousness is compromised, or turning them to their side to prevent them from aspirating. And then making sure that their call light's within reach, and that if they are experiencing delirium, that you don't leave them alone during that immediate post-op time. And then the next part is you're going to be watching for those complications. And so you're going to be watching for those things most likely to occur that are going to mess up this process of them getting better. So the first one is respiratory issues, and we're going to go into a little bit more detail about this in a little bit. But remember that turn, cough, deep breathe, and sense spirometry is vital during that initial post-op time. Recognizing that if they have an abdominal or chest wound, we want to splint the wound with a pillow or a blanket held firmly against that wound when they cough. Activity is ordered. So again, those leg exercises, whatever's allowed mobility-wise, etc. If they are still NPO, they may still be able to take in ice chips. Remember, if we're counting ice chips as INO, it's half the amount. So 50 mils of ice chips is 25 mils of oral intake. So we're going to, many times during the post-op time, we will do what we call clear liquids, advanced as tolerated. And clear liquid simply means that whatever the substance is, regardless of color, if you hold it up in a glass, you can see right through it. It's essentially transparent, regardless of its color. So apple juice, cranberry juice, grape juice, even black coffee is considered a clear liquid. Okay, so clear liquids, as long as they're not nauseating, we advance to to full liquids, which are liquids you can't see through, and that includes soups and puddings, and ice cream and sherbet, and then eventually to the soft, and then ultimately to a regular diet. We're going to provide them psychological support, recognizing that that they have experienced a stressor that they may or may not have been willing to talk about preoperatively, but now they may feel overwhelmed and ready to talk. Recognize that some of them need spiritual support because they may interpret this event as something from a spiritual perspective. So if the specific nature of the surgery has symbolic meaning to them, then it may cause them to suffer what we call spiritual discomfort, or I can't think of the word, I'm so sorry. Spiritual distress. Okay? And then lab values. The nurse is going to monitor those lab values for trends, and many times it's some of the same lab values that we looked at preoperatively. So their kidney function, their CBC, their chemistry panel, etc. And then part of our post-op is planning for that discharge time. Recognize that sometimes the patient will go home, sometimes they will go to a long-term or intermediate care facility, sometimes they will go home by themselves, sometimes they will go home with family. But we need to make sure that whatever their needs are, whoever's going to be there knows what they need to know to be able to provide that care. All right, so now let's go to some specific post-op complications. And I've divided them in two different ways for you. The first one is our ABCs, and there is no significance as far as me doing ABCs first versus the other one. It's simply the way I chose to do it. So don't think that one is necessarily more important than the other. Just recognize that we use the ABCs because our oxygen need is our greatest need, so it's our highest priority need to meet, even during the post-op time. So when it comes to airway and breathing, remember that they may have a compromised airway due to a decrease in level of consciousness, or they may have a compromised airway due to a laryngospasm when the ET tube was removed. So when the tube was pulled out from the vocal cords, it could cause a spasm. So what can we do about those things? Sometimes when they have a decreased LOC, we'll place an oral or nasal airway until they're more awake and alert and can maintain their own airway. We might position them on their side to prevent aspiration, to make sure that if they do have any post-op nausea and vomiting, it doesn't end up down in their lungs instead. If they do have a laryngospasm, we can use an Ambu bag and provide positive pressure ventilation, and it will subside within a few minutes usually. Sometimes we need a suction. Sometimes we need to do a nasotracheal suctioning of that client to clear their airway. Sometimes they need oxygen therapy. And then we want to begin that process of taking deep breaths and coughing to help clear out any anesthesia that's still residual in their lungs. When we're talking about circulation, we're primarily talking about hypotension and hypertension during this post-op time, recognizing that the client could experience either one. So based on their history would help you as a nurse to predict which one would you most likely see for that client. So what are we going to do for this one? Well, we may have to place the client if they have a hypotensive event in a modified Trendelenburg, or just flat and supine until we can get venous return to improve and their blood pressure to come on. Many times, once we replace the fluid loss, or once we get the anesthesia to wear off, the issue will be resolved. The surgeon may tell us to give them a fluid bolus, an IV fluid bolus. So even though he may want us to give it at 125 mils an hour when they get to the floor, we may have to give it as a bolus when the client's blood pressure begins to drop. Sometimes we have to give medications to support, so vasopressor medications or cardiac medications to help improve that person's blood pressure. And that would also include help bring down someone's blood pressure as well. If the client's problem is a loss of blood, and now they have hemorrhaged enough that their hemoglobin and red blood cell count are too low, then they may require that blood transfusion now. So one of the things that we need to know is what their INO is. So we're going to monitor that on all post-op patients, especially any client who's had a major procedure. And recognize that if hypertension is their problem, they may require a diuretic because of chronic illness, cardiac or renal. They may need a diuretic to get rid of surplus fluids that they received during surgery. All right, any questions about the ABCs? Okay. This next part you could call the 4 W's, or you could, the newer term is 5 W's. 4 W's represent the 4 things during the post-op period that can cause a rise in fever, a rise in a person's body temperature. The 5th W doesn't typically cause a fever, but it does start with the W if you use a specific word. So sometimes you'll see it in the literature as 5 W's, but I still prefer the 4 because I like to think about it as fever-producing problems. So the first one is wind. And so with wind, we're talking specifically about the client is at risk for developing pneumonia, atelectasis, or PE, and they're most apt to do that during the first 1 to 2 days post-operatively. So that respiratory hygiene, that incident spirometer, turn, cough, deep breathe, if they have nebulizer treatments ordered, all of that becomes very significant. Maintaining hydration, maintaining mobility, so to minimize the risk of a pulmonary emboli developing, all of those things is part of that process to prevent that from occurring. So I listed those things on there for you. Recognize sometimes for pneumonia, we would be administering antibiotics or nebulizer treatments, or even doing that chest percussion that we talked about before. Okay, when we're talking about wound, we're talking specifically about the surgical wound. So infection, dehiscence, or evisceration are 3 of the big ones that could occur with that wound. And typically these occur during the first 5 to 7 days post-op. They don't typically occur right after surgery. Typically they are a result of an infection that is developing within that tissue, making the wound where it does not heal normally. It doesn't heal at the right speed or right rate, if you will. Now sometimes that can be due to obesity, but sometimes that is due to diabetes and hyperglycemia, and sometimes it's due to infection itself. But basically, when we talk about a post-op wound, what we typically see on those first 1 to 2 days is what we call a sanguinous or a bloody drainage on the dressing. It looks pretty much like just frank blood initially. And then gradually, as the capillaries begin to heal, it becomes serosanguinous. And then lastly, it becomes serous, where we really don't see much red blood cells, just the serous fluid. When a person's wound, the drainage begins to go the other direction, that's a warning sign that they are probably going to experience dehiscence or evisceration. Okay? How do we prevent it? Using good hygiene, proper nutrition for our client, that splitting like we talked about, and making sure we're doing proper wound care. Recognizing that proper wound care includes specifically the surgeon removing the first dressing. Typically, if a dressing becomes saturated during the first 24 hours, typically we reinforce. If it saturates as a second time, so it looks like it's more than what we expect, we call the surgeon, and he or she may come and address the problem. Otherwise, he may tell us to continue to observe, and then he will check the wound 24 hours after that surgery. So signs and symptoms of an infection are those very things that we talked about with inflammation, with the exception that we're going to add the purulent drainage. Purulent meaning pus-like. Okay, so that's the white, gooey, nasty looking stuff. Dehiscence, the drainage will often have a pinkish tint to it, and sometimes the client will say, I think that something popped when those sutures break loose. So I've listed just a simplified version of that table that you have in the book, but basically you're going to call the surgeon or rapid response team staff. You're going to lay that client down, raise the head of the bed. Typically we're talking about an abdominal or chest wound when we're talking about this kind of wound. We're going to check their vital signs in their wound and look at what specifics we're dealing with. Then we're going to pry a sterile normal dressing to that suture line and keep it moist and apply pressure so it does not become an evisceration. An evisceration is when the organs themselves actually come out of the wound, and that becomes a life-threatening emergency. So once again, we're going to call that surgeon team or rapid response team. We're going to do the same thing, basically the same steps. We're going to make sure, though, that we do not push the organ back into the wound. We simply keep it moist and warm so that the blood vessels, when they are outside of the skin, dry out very quickly and then they die. And so the organ itself will die if we allow that tissue to dry out. And then make sure you stay with the client. Okay? It's a terrifying event for that individual to see your own guts coming out. And is it the third one? The third one is water. So when we're talking about water, we're primarily talking about a urinary tract infection. And the most common cause during post-op time is the placement of a Foley catheter. You may have heard the term CAUTI, which is a catheter-associated urinary tract infection. As part of the SCIP project, it is expected that unless there's a justifiable cause, that all Foley catheters placed during the perioperative period are removed within 48 hours of surgery. So we call it post-op day number 2 to minimize the risk of infection. Typically, if left in place, that catheter may become infected somewhere around 5 to 8 days after the surgery occurs, and they have fever, pain, and urinary frequency. So what do we do for these people? Well, we try to provide good catheter care when they need it, and then remove it as soon as they no longer need it. As soon as they are able to use a bedpan or able to use a bedside commode, we switch them to that. And then if they do develop a UTI, we're going to send a UA, administer the prescribed antibiotics. Cranberry juice is sometimes used to alter urine pH and can also improve the outcome for some patients. The fourth W is WAP, and it pertains specifically to thrombophlebitis. Thrombo meaning clot, phlebitis, meaning inflammation of the blood vessels. Okay, so it typically takes longer to develop, but we start preventing it from day one. Actually, for some patients, high-risk patients, we actually do begin our interventions during the pre-op time. What we observed is unilateral pain, swelling, and tenderness. And I say unilateral, meaning that if they have swollen extremities that are equal or roughly equal bilateral, that's typically heart failure or a fluid and electrolyte problem as opposed to a thrombophlebitis problem. Okay. So what do we do to prevent? Well, we try to prevent it by applying those head hose, SCDs, so sequential compression devices. Probably several of you have had them already on your patients in clinical. Foot pumps are like SCDs, but they simply apply pressure to the sole of the foot, and they apply pressure on that part of the blood vessels on the bottom side of the patient's foot called the plantar plexus. And by compressing and releasing, it accomplishes roughly the same thing that an SCD does. It basically forces blood back to the heart from the furthest point in that person's body. Leg exercises are also an excellent approach, and you've got a chart that shows you some examples of those that you could teach a client. But ambulation, early ambulation is the gold standard, meaning that the sooner we can get that patient out of bed, we benefit them in multiple ways. So even though they might be wearing tent hose and we have to put them in those non-slip socks, the sooner we can get them ambulating in the hall, the less likely they are to get thrombophlebitis. And then, I don't think I put it on there. I don't know where I put it, but another thing that we use prophylactically during this time is enoxaparin, or an anticoagulant that some of you have given in clinical already. Remember that I'm so sorry. DVT and PE prophylaxis is part of the SCIP project. Okay, so it's listed on that SCIP chart. If they develop thrombophlebitis, they develop a DVT. In order to minimize it becoming a PE, they will often be placed on bed rest for a few days while we anticoagulate them to a higher level than the enoxaparin. And then the fifth W, some people would refer to as waste. It doesn't typically cause a fever, so that's why I said I don't refer to it as the fifth W, but you might see it listed that way. It's an ileus, which simply means that the valves do not move. The valve's peristaltic activity has stopped. Typically, it's expected for about 3 days postoperatively if the patient